Welcome to Pathology Central Key Concepts. The topic of this video is mediators of inflammation. Now, depending on where you are in your healthcare education, inflammatory mediators may be really overwhelming. There are a lot of them. They have similar names. They have overlapping and distinct actions. So it can be very hard to conceptualize these. So the goal of this video is to provide some context using some really nice figures to help you organize your thoughts about inflammatory mediators and their effect on the body. So with that in mind, I will be describing a variety of different inflammatory mediators and reviewing the systemic effects of inflammation. So what do inflammatory mediators do? What is their role? It is to initiate and regulate inflammatory reactions. Now, they may be cell-derived, such as histamine and the prostaglandins, or they may be in the plasma, such as complement proteins. And they are typically short-lived because you don't want to have ongoing inflammation in the body because that can cause damage. So you have a short-lived inflammatory mediator, it will decay, it will die, but if the stimulus is still there, other cells will continue to elaborate inflammatory mediators, but each of those will be short-lived. And they can have a cascade effect where one mediator stimulates a cell to elaborate other mediators, so you get amplification of a signal. Now, we can consider them to be two general categories, cell-derived and plasma protein-derived. And the cell-derived mediators can either be preformed mediators that are released in secretory granules, so this includes histamine, which is an important one, and serotonin, but the majority of them will be newly synthesized in response to a stimulus, so this will include the prostaglandins and leukotrienes, etc. Now you can see that we have a list of a variety of different cells that elaborate these. EC stands for endothelial cell. And I think it's basically important to recognize in general the types of cells that release these mediators. However, in any inflammatory reaction, you're going to have all of these cells releasing different mediators. So don't focus too much on the various sources. Now, as we talk about the plasma protein ones, almost all of those are going to be elaborated by the liver and they will be released into the plasma. So these will be our complement proteins, which are listed here, and then ones that are involved in the kinin system as well as the coagulation and fibrinolysis system, which we talk about in the coagulation video. This is a really nice table from Robbins Kumar Basic Pathology 11th edition that it goes again over what the different mediators are, what the sources are, and what their actions are. And I'm going to go through these in a little bit more detail, but I think that these in the red box are the ones that you should really pay attention to. Histamine in particular, the prostaglandins are going to come back again and again. Leukotrienes have a role in asthma, and then the cytokines, we're going to go into a lot of detail on these, and there are a lot of cytokines. But you can see that they have different effects. So histamine is notable for vasodilation, increased vascular permeability, which will lead to edema, endothelial activation, which can lead to a variety of different impacts, such as increased thrombophilia. And then we can see the prostaglandins are involved in vasodilation, pain, and fever. And you can go through this. And I think this is probably worth knowing because typically we discuss inflammation early in medical school. And you're going to see these again and again and again. And you're going to see them in the context of different organ systems as well as in the case of the pharmaceuticals that are used to treat the variety of effects. So I'm going to take a moment to talk about a couple of mediators that are particularly important clinically. So tumor necrosis factor and IL-1 have overlapping activities. They are involved in leukocyte recruitment, endothelial activation, leukocyte activation, and the systemic acute phase response. That latter is along with IL-6. Now, I'm going to talk about the systemic acute phase response at the end of this video, and I talk more about endothelial activation in the thrombosis lecture, as well as in atherosclerosis. Now, tumor necrosis factor is important because it does a lot of things. So one of the things it does is it regulates energy balance by promoting lipid and protein catabolism and by suppressing appetite. And this is important to recognize at this point when we're talking about mediators. I want to give you some clinical context so you're not just memorizing these. Tumor necrosis factor is frequently elaborated in the context of malignancies, particularly in widespread malignancies. And this accounts for the cachexia, the severe wasting that we can see in patients with advanced cancers. The other reason why it's important to be aware of tumor necrosis factor is because tumor necrosis factor antagonists are used in the treatment of chronic inflammatory diseases, such as rheumatoid arthritis. IL-1, as I mentioned, has overlapping activities with tumor necrosis factor. However, IL-1 antagonists have not been found to be as useful in the treatment of chronic inflammatory diseases. But you're going to see this again when we talk about immunopathology. Now, this is, I mentioned something about the leukotrienes, then there are the prostaglandins, and I want to put this into a context for you so you have an idea of what we're talking about. So here we have our cell membrane, and we have some sort of stimulus which is going to drive us towards inflammation. And the first step that's going to happen is that phospholipase is going to cleave here, the cell membrane phospholipids, to elaborate this product, arachidonic acid. So all of these that we have down here are referred to as arachidonic acid metabolites. Now, one of the things that's important about this is to recognize that this is where steroids interfere. So if you have a patient who has a chronic inflammatory disease, such as autoimmune hepatitis, and you give that patient steroids in order to calm down the immune system, this is where that steroid is acting. And that gives you some information because that's telling you that you're shutting down all of these downstream activities. Now, arachidonic acid can then go through two different pathways depending on which enzyme is used. So the first pathway we'll look at is cyclooxygenase. And this is important to recognize because you're going to see this in your pharmacology lectures that cyclooxygenase can be impeded by COX-1 and COX-2 inhibitors. This is going to include as well aspirin and indomethacin. So this is the role here when we talk about aspirin is going to shut off cyclooxygenase. So that's going to shut off everything downstream. What do we have downstream of the cyclooxygenase pathway? We have thromboxane A2, which is involved in platelet aggregation, amongst other factors. And this is one of the reasons why for elderly patients who are at risk for myocardial infarction or stroke, it has been recommended to give a baby aspirin. So you can see here, I'm hoping that this is bringing home to you how this cascade works. So we have these two intermediates that you really don't need to focus on, but you know that downstream of this pathway of arachidonic acid through cyclooxygenase is going to result in prostacyclin I2, also referred to as PGI2, which has a role in inhibiting platelet aggregation as well as causing vasodilation. You can see this nice figure, this vessel is dilated, compared to thromboxane A2, which is going to cause vasoconstriction and platelet aggregation. We also have PGD2 and PGE2, and they play a role in increasing vascular permeability and as chemoattractants for neutrophils. So this is PGD2 and PGE2. And you're going to see this in a variety of different clinical scenarios, for example, in asthma. Let's go now down the lipoxygenase, 5-lipoxygenase pathway. Once more, you can use pharmaceuticals here, a lipoxygenase inhibitor. As you go down through this pathway, you end up with your leukotrienes, so LTB4, and then with the action of 12-lipoxygenase, you get lipoxin A2, lipoxin B4. And these, again, have a variety of activities. We come down through this pathway, leukotriene A4 is going to take us through LTC4 to LTD4 and LTE4, which are going to lead to increased vascular permeability and bronchospasm. Why is this important? These are mediators that we see in asthma. And so typically patients with asthma can be treated with steroids to reduce inflammation, but a more specific way of just addressing the bronchospasm will be leukotriene receptor antagonists. So the thing to be aware of here is that you can use different pharmaceuticals to address different mediators in this cascade. And you're going to be seeing again and again thromboxane A2 because we'll be talking about that in the context of coagulation as well as coagulation disorders. And as I mentioned, you will see these in the context of asthma. So this is just to sort of put it together into a table once more from Robbins and Kumar Basic Pathology, the principal actions of the arachidonic acid metabolites and what their names are. And so you can see here vasodilation, vasoconstriction, increased vascular permeability, and then chemotaxis and leukocyte adhesion. All right, so let's look at this again in the context of disease. So type 1 hypersensitivity is something we'll be talking about when we talk about immunopathology in Robbins and Kumar Basic Pathology. But I wanted to bring this in here so you can see how these different mediators have an impact on the body. So if you have an activated mast cell or basophil, we're going to get release of all of these different mediators. So your vasoactive amines, such as histamine, which are going to cause vasodilation, and that's also going to cause vascular leak and edema. We have our lipid mediators, PAF, PGD2, and LTC4, which are going to take us through this pathway. We have bronchoconstriction, intestinal hypermotility. That's something you can see in patients who are having an anaphylactic reaction. We have cytokines such as tumor necrosis factor and our lipid mediators coming from our arachidonic acid metabolites leading to inflammation. And then enzymes that are released by these that are going to cause tissue damage. So all of these mediators you're learning about are part of a very complicated soup of feedback and reaction and inhibition, which is driving inflammation and also ending inflammation. So here is now looking more specifically, I've already invoked tumor necrosis factor and IL-1. I want to go into a little bit more detail about cytokines. These are small molecules that are released by a variety of different cells, and they have a number of different actions in inflammation. So this comes from table 2.6 from Robbins and Kumar Basic Pathology 11th edition. I added a little bit here in healing to bring in TGF-beta. But again, tumor necrosis factor, we talked about how it stimulates the expression of endothelial adhesion molecules and secretion of other cytokines and has systemic effects, which I discussed earlier. IL-1, again, is similar to tumor necrosis factor, but has a greater role in fever. And then IL-6 is something you really want to think about when we start talking about our acute phase response, and that's going to be a little bit later in this video. We have our chemokines, which are secreted by a number of different cell types. It looks like almost every cell can elaborate some sort of chemokine, which is going to recruit leukocytes to the site of inflammation and migration of cells to healthy tissues. So it is bringing your inflammation to the appropriate site. Now, this is what we see in acute inflammation. It's important to distinguish that from the cytokines we see in chronic inflammation. And again, I have a video on acute inflammation alone and one on chronic inflammation. And I recommend those to get a better idea of what each of these groups of mediators do. Now, IL-12 is elaborated by dendritic cells and macrophages and causes increased production of interferon gamma. Interferon gamma has got a very important role in the activation of macrophages, so increasing our ability to kill microbes and tumor cells. So this is one of the activation pathways of macrophages, the M1 pathway. We'll see M2 macrophages when we talk about healing, and that's through a different mediator, TGF-beta, which is going to drive the synthesis and deposition of extracellular matrix proteins. So you can see that we have macrophages that are going to go in different directions depending on the mediators that are involved. And then here we have IL-17, which is elaborated by T lymphocytes, which is going to cause a recruitment of neutrophils and monocytes. So this is a good table, I think, for putting everything into context and thinking about which mediators you will see in which pathologic condition. Now let's work through here a figure that's going to show us again, right? Because I like to come at this from different angles. So we have local inflammation, so perhaps a cut or a splinter. And we're going to get the elaboration of TNF and IL-1, which are going to cause endothelial activation, increased expression of adhesion molecules. So we're going to get a somewhat prothrombotic area here. This is what we see with endothelial activation. Increased permeability is going to lead to edema. And then we're also going to get from the endothelium the release of IL-1 and chemokines. So this is a feedback loop where one cytokine is going to cause the elaboration of itself as well as other mediators. Another thing that we can see is activation of leukocytes in other cells. So again, TNF and IL-1 are going to have an impact on macrophages, causing them to elaborate IL-1, IL-6, and chemokines in the case of local inflammation. TNF and IL-1 are also going to have an impact on neutrophils. It's going to be an enhanced neutrophil response to other stimuli. And then we have IL-1 and IL-6 working on T cells, which will then elaborate IL-17, stimulating other cell types to release chemokines. So what is going to be the effect of this just veritable soup of inflammatory mediators? Well, we can have systemic protective effects. So TNF and IL-1 can affect the brain to cause fever. We have IL-1 and IL-6 are going to stimulate the liver to elaborate acute phase proteins. More on that in a moment. And then TNF, IL-1, and IL-6 will act on the bone marrow to cause release of leukocytes so that we can get our leukocytes that will be migrating from the bone marrow into the circulation to address inflammation. But all of these cytokines are not just protective, they can cause damage as well. So they can have systemic pathological effects. So tumor necrosis factor can affect the contractility of the heart, leading to a decrease in cardiac output. As I've already mentioned, tumor necrosis factor can cause some activation of the endothelial cells, which can be thrombophilic. We have that increased permeability, which can lead to edema, and we have vasodilation. And then finally, we can get TNF-IL-1 having effects on a number of different tissues. So I've already mentioned tumor necrosis factor in the context of malignancy. What it does to the skeletal muscle is it increases insulin resistance and causes loss of fatty tissue. So this is going to lead to that cachexia that we can see in malignancy. Now I'm going to go to another figure. This comes from the circulatory dysfunction material, and this is very complicated, so I'm going to cover this up and just focus on this. So again, okay, this is in the context of inflammation, where we have our neutrophil and our monocyte that are responding to stimuli from caused by inflammation through the toll-like receptor to release cytokines and cytokine-like mediators. We have the influx of our complement proteins to this pro-inflammatory state. TNF-IL-1 combining with stress-induced hormones are going to cause these metabolic abnormalities. So insulin resistance, hyperglycemia, and this is in the case of shock. You can go on to multi-organ failure. And this can also be pro-inflammatory through the action of endothelial activation. So that's talking about mediators in inflammation. What about mediators in healing? So how does the body respond to injury in a positive way? So here we'll be looking at tumor growth factor, transforming growth factor beta, which has got a lot of different roles. So the synthesis and deposition of connective tissue protein, inhibition of matrix metalloproteinases and endothelial cell proliferation, and it also causes fibrosis in the lung, liver, and kidney, and has anti-inflammatory effects. Now, that is one of the mediators that's very important in healing from injury. These three are all going to be involved in angiogenesis, so in the formation of blood vessels to deal with areas that have been injured. So we have vascular endothelial growth factor, or VEGF, which is involved in angiogenesis. Fibroblast growth factor stimulates endothelial cells, and platelet-derived growth factor stimulates smooth muscle cells, so that we have angiogenesis. Now, I'd like to take a little bit of time to talk about the systemic effects of inflammation. So this is, again, due to the mediators that are having this response. I already talked about IL-1, how it can cause fever, which enhances the immune response. We have a variety of mediators that are going to cause leukocytosis, so the migration of lymphocytes from the bone marrow into the circulation where they can be more effective. And then we have the acute phase proteins that I've mentioned a few times. So this will be C-reactive protein, serum amyloid A protein, and fibrinogen. So we call these CRP, SAA, and fibrinogen. Now, C-reactive protein is elevated when you have any type of inflammation. So it is a good way of assessing the inflammatory state of your patient. It also can be used to look at cardiac risk because atherosclerosis is a pro-inflammatory state. And if you see that a patient has elevated CRP, that's telling you that they have an increased risk of atherosclerosis and atherosclerotic heart disease, as well as myocardial infarction. We also have serum amyloid A protein. This is something that we typically associate with long-term chronic infections. So for a long time, tuberculosis was the primary disease associated with serum amyloid A protein being elaborated. Now it's going to be something more like rheumatoid arthritis. Sometimes you can see it in patients with long-standing infections. And what this protein can do is it can form these insoluble sheets of protein that, depending on where they're deposited, can have a variety of different effects. In the heart, it can lead to a restrictive cardiomyopathy, which you can learn more about in the cardiology lectures or cardiopathology lectures. And then finally, the last one of these will be fibrinogen. And fibrinogen plays a role which is quite important in the formation of rouleau. So let's talk about rouleau. So this, in the typical red cell, is going to be covered with negative charges, and that will repel the red cells from each other. When you have acute phase proteins, particularly fibrinogen, you're going to get coating of these red cells, and it's going to cover up that negative charge, and they will now be able to stick together, forming what are called rouleaux, forming these just sort of stacks of cells that are stuck together. Now, this is important because it lets you know that the patient is in a pro-inflammatory state. So how do we measure this? So there's a laboratory test we can use called the erythrocyte sedimentation rate. And the reason this is important is because we can see that when you have these chains of red cells, these rouleaux, these are going to sediment or fall more quickly than these individual red cells. So the erythrocyte sedimentation rate is going to increase, and this will let you know that your patient is in a pro-inflammatory state. Okay, so I'm just going to finish with a few questions to see your understanding of the material. How do steroids reduce inflammation? What are the physiologic and pathologic effects of tumor necrosis factor? And what are the acute phase proteins and what do they do? I hope that you have found this useful. Please follow me on Twitter, shoot me an email, comments down below. Thank you.